I want to thank Tactile for giving us this platform tonight to really talk about lymphedema and where we're going. But before we start, I really need to take a moment to acknowledge the impact of the COVID-19 crisis and the events that are enveloping our country right now after the tragic death of George Floyd. We all know that significant racial disparities exist in this country when it comes to healthcare. And we also have great economic disparities that are developing and have already been there due to COVID-19. So with that, tonight is really an opportunity for us to all come together to share our voice in a group sharing event. And it's really a call to action for each and every one of us to not only do better, but to speak up and be part of the solution. So I would like to introduce my esteemed panelists tonight, and they'll each introduce themselves.
So my name is Elise Cantu. I am a physical therapist in Fort Worth, Texas, and I specialize in oncology and lymphedema treatments. I'm also the host of the OncoPT podcast. And in this method, I educate new and aspiring clinicians on how they can impact our patients through oncologic physical therapy.
My name is Kimberly Miller. I'm a nurse practitioner at MedStar Georgetown University Hospital in Washington, D.C. I work under Dr. David Song, who performs breast cancer reconstruction, as well as all the forms of lymphedema surgery, lymph node transfer, lymphovenous bypass, and even liposuction. And I'm responsible for a lot of the pre-op and post-op of the surgery patients. So I've gotten the opportunity to work with lymphedema therapists closely and have leaned on them a lot for their guidance with my patients. So very excited to be here tonight.
Hi, I'm Linda Hodgkins. I'm the clinical program director for Hartford Healthcare in Connecticut and have been treating lymphedema as a lymphedema therapist for over 20 years. I'm directing a large program in Connecticut with 14 different sites and 24 clinicians that are certified lymphedema therapists, and I'm a faculty member for close training.
Well, thank you all. I forgot to tell you, my name is Maureen Macbeth again. I'm a physical therapist and a certified lymphedema therapist. And I also have been teaching for many years for the Norton School of Lymphedema Therapy. I also have a consulting business, and that's how I'm on the Speakers Bureau for Tactile. And I work in private practice in a small practice in Columbia, Maryland called Forever Fit Physical Therapy and Wellness. And this is really my idea tonight to follow up on the first webinar that we had in early April after COVID-19 hit. So the catalyst was an exercise that I've done before with something called clarity cards. And clarity cards are actually this little deck of cards. You can, kind of see them here. They were developed by Matthias Jakobsen, and he's just this amazing person who gets people to think more clearly, and his website's actually called Think Clearly. So the four of us actually sat down and did an exercise, and it ended up looking like what's on your screen, but we actually wrote on paper with pen, so it was kind of old school, and we really created these group reflections, and was based on the 4 questions that we're actually going to ask you tonight too. And, you know, pretty much the first one, I guess we can really get to it right now. And you're going to see that this is a very organic process. So the deck is divided into 4 different things. And the first set of cards are facts. And you kind of randomly pick one. And our card said, what is happening right now? So with that, I want to actually ask a question of the audience. And you have a polling feature. So what you can do right now is pick any of these that apply. And we're going to just give you a couple seconds. Now, I can see this in real time, so get those votes in. And we're trying to find out where and if people are still working, if people are furloughed, if you're doing some hybrid. Okay, wow, it's starting to come in. Okay, wow, it's all over. You guys are fast. But it's looking like about 20% are part-time or reduced hours, 30% full-time, 22% furloughed, only 9% doing in-person, 6% say telemedicine. You can hit more than one. Okay, and maybe there's like a mix, 11%. So these numbers are holding pretty firm, that we have about 32% of you still working full time. But as we can see, a lot of people have had reduced hours and are furloughed. Okay, so we're gonna kind of move on then to this first, and I'm gonna share those results. Okay, so I'm gonna actually let Linda jump off with this first question about what is happening right now, Linda, in your world.
So, we still have patients with cancer that are getting treatments and developing lymphedema. And what was difficult to access before COVID has become inaccessible for a lot of our patients, particularly those who are immunocompromised. Some of that's fear of coming in, and some of it is just not having access to care. At our particular site, we have furloughed, we really haven't furloughed our therapists. We've redeployed some to other jobs, but we do still have our clinics open. And what we've seen, March and April were really tough. We were really slow. A lot of patients just didn't want to come in and didn't feel comfortable. But our numbers just came in for May, and we're starting to see that some patients are feeling more comfortable, and we are seeing that the clinics are starting to get busy again. But I think for those with immunocompromised issues, they're still not comfortable to come in and be exposed possibly to COVID.
So I'm going to turn and ask Kim. Kim, I know one of our mutual patients is actually coming into the clinic tomorrow. So you're starting to see people in the clinic. How is that transforming right now? And what's happening for you in Washington, D.C.?
Yeah, so as far as clinic, we have been doing both telemedicine and in-person. With PPE, we have allowed the in-person option. We are at a hospital where they have COVID patients. So it is something that I agree with you, Linda. Most patients have reached out to me just assuming that they can't come in or not feeling comfortable coming in. And I know I had mentioned to you guys that I'll get messages or emails from patients. I have a burn, I have lymphedema, I have a burn. I would normally go to the urgent care. I don't feel comfortable going to urgent care. How can you help me? Or I have increased pain. I would normally see my therapist. She would work it out. Now I don't feel comfortable. So we are having patients come in for assessments. Especially our patients, breast cancer surgery patients who need drain removals do need to come in. But we have allowed the telemedicine option too. But as far as surgery, we haven't been able to do elective surgery for the past 3 months.
And is that just for the lymphedema surgeries or which of the breast reconstruction surgeries, for example?
So as far as breast reconstruction, we've only been able to do immediate reconstruction with an implant or a tissue expander just to hold the space, but no free flap surgeries because those require a few day hospital stay. Some like immediate oncoplasties or mastopexy, but no elective surgery. And as we know, lymphedema is a chronic disease, but it will be seen as elective, even though a lot of surgeries have time constraints. They'll keep advancing, but we won't be able to do the surgeries until they're all backlogged now.
Yeah. So Elise, what's happening in Texas?
So as far as surgeries, a lot of my patients have told me that, they were initially scheduled for a double mastectomy, and when all of this was starting and things were closing, so with the decision of their surgeon, they chose to just do like a single mastectomy with the intent of somewhere down the road, when reconstruction is, kind of a viable option for what they want to do at that time, then they'll go in and they'll do the other mastectomy and then the reconstruction. As far as reconstructions, I know a lot of the surgeons in our area have even said we're not even doing inpatient visits. Some of them are doing some telemedicine, but it really depends largely practice to practice what we're seeing. A lot more of these patients are getting more of a conservative surgical approach, and then immediately jumping in with chemotherapy and whatnot. So again, it's kind of dependent on the surgeon's practice, but definitely more conservative as far as, no elective surgery whatsoever.
So that's really amazing. I love this was one of our comments when we did our exercise, that we're really in this holding pattern for disease that keeps on advancing. And, so this has been our concern even at the first webinar, is what's going to happen with all these patients. And so I just see this kind of extended care that's going to go on. So catching lymphedema early is really going to be critical. So I hope anyone in the audience, if you have any other comments that we can get out about the practice pattern changes you've seen. But I know in my area too, it's just that everything is just getting backed up. And so I just can't imagine the amount of work that we're going to have. And I just saw popped up in Austin, some plastic surgeons are starting to do elective surgery. So it's probably regional in terms of how this is happening.
Right.
Great. All right. So, our second card, I like this one, about feelings, because again, I randomly pulled these cards when we did our first exercise, and I liked it because it said, what am I excited about? And so I think there have to be things, right, that we are excited about. So I know, Linda, you had just said some wonderful things. So I'm going to let you kick this one off.
Yeah, usually I'm just treating all the time. And so to have some time to dream and to think about and evaluate our program and what could we do better. And like you said, with this backlog, how could we prevent more lymphedema than always treating it sort of after it's in this chronic progressed state? And so there's some really exciting initiatives that I've been working on and collaborating with other departments that I don't normally have a lot of collaboration with. Our Bone and Joint Institute, which is a hospital just for joint replacements. We're talking to those surgeons about, could we identify patients who are swelling pre-surgery before their knee replacement, for their hip replacement? Because if their lymph system is compromised prior to surgery, we shouldn't be shocked when they have a really tough post-rehab and filled with pain and not very good range of motion. So what if we treated those patients prior to the surgery with some CDT and got them under control and then had that connection? We're also thinking about our breast cancer patients, and so many of them struggle with trunk edema. And so why not get them a decent bra? I've been talking to Leslie Bell, who invented the Belize bra. And what if we gave every patient a kit that had an axilla pad, a Belize bra, and a bra extender, so the bra could fit around our surgical dressings, but then could fit for the next year when they have different swelling events, maybe after radiation or in the summer, and really attack trunk edema before it becomes lymphedema. And so just had time to dream about how can we do things better, and so we don't have such a backlog of all these patients that are in desperate situations. Let's be more preemptive with our care.
Yeah, that's awesome. And that's what Kim and I treat a lot of patients together, because we're geographically located near each other. And we were talking about that recently, about, what are the things that your surgical practice is going to do now that you have had almost a pause to sit and reflect on opportunities.
Yeah, I think that but even something as simple as telemedicine in the medical community, I think is definitely here to stay, especially anyone who's unfortunately had to go to Georgetown Hospital and the parking and, just getting there through the traffic. It's something that was a possibility even when I started 2.5 years ago, but not something that patients were comfortable with or that we used. But it's kind of forced a lot of medical providers to use, and patients then, the hope would be that they wouldn't be missed because they could even be seen at home. And working for a teaching hospital, even the way that we're educating all providers has changed. Before, you would go to a conference and spend a lot of money and pay for CEs, and now you can really do it from home and access people in different states, different countries, and share information. And I'm very lucky to have Maureen, but I've always felt comfortable reaching out to my lymphedema therapist or other interdisciplinary teams. But now I think everyone is starting to see the benefit of that, because we all want what's best for patients.
Elise, I'm curious, Elise, with that, because you've been fairly tech savvy since I've met you and starting your podcast and whatnot. And I know you're starting some projects. I'm not here to let you pitch that per se, but it is important to know that there's therapists like you out there trying to connect. I'm curious, have you seen an uptick in your online world?
I would definitely say so. And this isn't just, my platform specifically, but I think, not just in healthcare, but in general, because so many of us are stuck at home, whether that's because we're not working full time or because, working from home, can't go out and do things that we normally do. We spend so much time now online, and it's come with a beautiful advent of so many people are turning to very virtual electronic ways of education that previously, I think Kimberly, you nailed it when you said we had the capacity to do this. We just didn't do it. And now that we have to, we're seeing a lot of really great changes. And as, much as we'd like to kind of stay with, okay, this is how things have been working, we treat our patients X, Y, and Z, we're having to become really creative, especially with telemedicine. I think one of the things that really intimidated me when this was first starting was, how in the world am I going to do a telemedicine eval on a patient who has lymphedema? And the more that I've talked with other people about, yeah, this is possible and it's definitely doable. And we have at our fingertips so much to access. One of the beautiful things that, was really just divine timing more than came out because of this. But Balette Raffin and Kristen Campbell, just recently, their team came out with this beautiful video that instructs patients on how they can actually be measuring their own arms effectively with tools that they can find at their disposal. I mean, arm measuring tape that you can get off of Amazon, a marker, everybody has those. And then they actually told me it's one of the Starbucks stirrers that they use, and they can effectively measure, and the data shows this is working, and this is a good way for patients to determine, am I swelling? Am I having changes in my swelling, so that they can actually initiate coming back in or reaching out for services if coming into the clinic isn't feasible before it gets to be such a problem where swelling is out of control. And there's so much that was coming already, but then really came to the surface with the restrictions that we've experienced due to COVID.
Linda, before you jump on, I just want to let everyone know, Terry Kuti from the Deep Sea Foundation is here, a patient advocacy group. She just asked if you can get that video, and yes, you can. We'll make sure we publish that. And the article is out there. It's in the bibliography from my first webinar I did for Tactile. But the researchers got connected, and make sure you watch Elise's Onco PT podcast with them. It was a wonderful, wonderful meeting that was really international, with Dr. Raffin over in Europe and Dr. Campbell in British Columbia and Elise in Texas. But Linda, I know you were talking about a program that I think you're going to be starting in your hospital. Can you tell me a little bit more about that?
Well, we're doing virtual health, if that's what you're referring to. And that's what I was thinking about with what Elise just said is, some of these things are already in place. We were doing 6-month checkups with all of our patients, which I highly recommend, because many of our patients, especially if they're new to lymphedema, they're in that sort of anger and denial phase, and they're not always following through on things. And so if we sort of wait to let them come back, often they come back, like Elise said, when things are really out of control and they're way past baseline, where when we check in with them every 6 months, it sort of helps keep them accountable. And there's been good research with diabetes and other chronic illnesses that when people have accountability, when they have somebody checking in with them, they do much better. And so virtual health for us is now going to become a new avenue for doing that check-in, particularly for those patients who don't feel comfortable coming in, checking in with them at 6 months, looking at their garment. Is it fitting properly? Are they wearing it? And identifying those patients through virtual health, then bringing them in if we need to. But that touch base on virtual health can really help keep them on the right track. And that's really exciting. We just didn't have access to things like that prior to COVID. And I think that's one of the things that's going to come out of COVID that we are going to hold on to, and I think is going to be better for us and our patients.
Yeah, I mean, I think that's, before we jump into the insights, I mean, I just have to say, one of my patients, she's 77 years old, and she said this telehealth is making such a difference because it was so arduous to get into the clinic. And really what she needs is me to do some exercises with her, to look at how she's using her compression to help her problem solve. And she feels so supported right now. So I just, love what all the points you guys brought up. But, this next section that we're going to jump into in terms of insights, I always love thinking critically about what we're doing and really looking at what are the assumptions, that we're making about this though. And I think it's important because I know personally, I'll share one with you before I let you all take it over, but it was that I just assumed that some of my patients, because they were teleworking from home, would be doing better right now. And I have two really interesting cases that juxtapose each other. My patient with lower extremity lymphedema that used to have to stand all day at work is doing much, much, much better right now because she can bandage all day at home. She can grade her papers and even teach from laying down. My patient with upper extremity lymphedema is a physician, but she can't work in the clinic now. She's having a flare up. And so they've got her on telemedicine type things and computer work. And with her arm bandaged all day on the computer, she's having the worst flare of her life. So just, I'm going to let you, Elise, why don't you jump in on this? What are some of the assumptions and challenges that you've seen?
One of the big things that I've been seeing, and not just in therapists that I'm working with, but also those who are reaching out to me as far as, we know that our patients need us. This is obviously well established. We're all here because we care about treating our patients, but we're at a real crossroads right now because we've been operating under this kind of go, go, go for so long that we've had this conversation off air, but we're looking at a potential second crisis after COVID. I'm not talking about a second wave. I'm talking about therapists who are so overworked because we already know there's not enough lymphedema therapists out there. We know this is well established, but we are working so hard for all of our patients that I think it's a real concern that we could see some real significant burnout in the medical community period. But I think, with all of the things that we're talking about and how much that we as healthcare providers are taking on for our patients, especially for those patients who have such a unique issue as lymphedema, we could potentially see some real problems very, very shortly on this. And, this idea of we have to treat lymphedema how we've always treated it, we can't do that anymore. We have this idea of this is how it's done. Well, sometimes we can't always do that. So how do we effectively pivot in order to empower our patients to start self-managing earlier so that, they can take care of this when they aren't able to come into the clinic and, maybe telemedicine is our only option.
Well, I'm going to put Kimberly on the spot because we've talked about this. You as a nurse practitioner, we really rely on the referrals. And, I just have to say, you've been excellent at that since you've understood how much that relationship with the therapist. But you also said something interesting the other day about how that telehealth will hopefully allow us to reach more people. And it may get those patients who maybe didn't want to come, for example, all the way into Georgetown to show you something that they thought was mild, and it's really not. So go ahead and tell me a little bit more about what we were talking about the other day.
Yeah, and I even think, one of the biggest things I feel like you and I talk about is not even prehab, but getting measurements before someone has breast surgery or before someone has chemotherapy. So that's really hard. I can't catch those people a lot of times because they might have breast surgery first or they might have neoadjuvant chemotherapy. And so that's something that I know is really hard by the time a patient gets to a lymphedema therapist. Their limbs might have always been a different size, and how can you tell that, or is it lymphedema? And if there's no pre-op measurements, how can you find stage 1 or stage 0? You can't, and then they will show up later when it is a bigger problem. And that's especially hard because a lot of surgeries, do better when they're sooner. And even therapy, of course, works better when it's sooner. So, I mean, at least I love that idea of people being empowered to do their own measurements, because in theory, then as long as we're educating those patients, how could we miss them if they're educated to do that prior to everything?
Right.
We've talked about collaborating, Kim, our teams collaborating more, the therapy and oncology. And I think having machines like the SOZO in the oncology office that can take a bioimpedance measurement prior to surgery and after is going to more accurately identify those patients with latency lymphedema and then triage them to therapy as needed. And just getting a sleeve from oncology if the LDEX goes up. I think we have to collaborate more, and that will take some of the pressure off of the lymphedema therapists if the oncology team is willing to sort of own those SOZO machines and getting that LDEX reading prior to surgery. I think that's going to eliminate a lot of lymphedema, and it's going to eliminate a lot of the backup that we see, all these patients that are getting lymphedema that wouldn't have if they had gotten, that SOZO, had that impedimed measurement.
Yeah, Brenda, that's a great point. And I don't know if anyone else was following what's been going on at ASCO. Even though the oncologists couldn't go to Chicago this year, the ASCO meeting went virtual. And I know they released some of the PREVENT trial information about that, that they can catch lymphedema so much earlier. And we were having a discussion about this because I just had everything you guys just talked about. Had a lady come in, she was treated in another city, had no pre-op, no prehab. So she comes in, she's like, well, I think this arm feels bigger. And it was bigger, but it was her dominant arm. And she had truncal lymphedema. So I'm literally already filled out the paperwork because she absolutely needs to get like a tactile device. She needs the Flexi Touch because she can't come to see me all the time right now. She doesn't have insurance coverage for my clinic, and she's going to be paying out of pocket because right now the local clinics, they can't get her in. I have someone else who's been waiting since March 31st to come in, who just found me. And this economic mixture, this wait list mixture that we're going to have is going to be critical. So we're going to have to get people tools, and we're going to have to use smarter tools. I wish if anyone out there is a surgeon, call Kim, please, because we've talked also, and Kim, if you could quickly comment on these adaptations we may need to make in terms of how we utilize our social connections, like you as a nurse practitioner. Can you call the breast center and say, we've got to do better, help us out, and all get together?
Right. And I know Maureen always says, reach out to your mid-level providers, because they really do they do have so much access to patients and more time even than surgeons to make those connections and collaborate with other teams. And we all have the same goal in mind, and everyone wants, lymphedema is still so misunderstood by the medical community and by patients and underdiagnosed. And we really need lymphedema therapists on the team. Maureen, you have caught so much in our patients just from assessing their volume and their extremities. So
yeah, and using that mixture. And there was just a comment that came in over, I'm going to quickly address, but someone asked what the LDEX was, and it's bioimpedance spectroscopy. So it's using a small electrical current to measure extracellular fluid. And right now, it's seen as a way to detect changes before even volume could detect changes. And so, there's really an emerging paradigm that I talked about in the last webinar of, if you're a surgeon and you have access to ICG, indocyanine green imaging, you can actually detect, changes in the lymphatic system that can show the decreased pumping, the backflow, dermal backflow. And so we really have to start to look at lymphedema from more than one lens. We can't just diagnose it one way. We have better technology. And so I think this is a perfect segue into this whole action piece. So this was sort of the fourth part of the exercise. And the card we had selected was, what am I going to do now? So I'm going to just put that out there. I think I was going to pick one of you. I can't remember who, but just someone jump in. And, you know, Elise, I haven't heard from you for a few minutes. What are you going to do? What's your vision?
You know, and first of all, there's so many things, obviously. But there's no reason why these patients shouldn't be getting to us anyways. You know, I unfortunately had a patient just a few weeks ago who had a mastectomy and then came in for actually a prehab visit. Well, she was already developing lymphedema, and I unfortunately had to be the one to tell her, yes, it is lymphedema. And she went back to her breast surgeon, who said, no, it couldn't possibly be lymphedema. It's too early.
Yeah.
So, you know, unfortunately, this is still an issue that we're facing. And so I think just really trying to educate patients, of course, but also their caregivers and their other healthcare practitioners on the oncology team, for example, and even in the community, getting out there and being aggressive with, this is a problem, and then emphasizing the urgency. Because I think a lot of people, you know, Kimberly mentioned that, you know, lymphedema is still so misunderstood or not really understood, especially by patients and sometimes even the oncologists. You know, not to throw anybody under the bus, but we're still learning about so much of this. And so getting out there, being aggressive with the education and emphasizing the urgency that we need to get you in here so that we can stop the advancement, you know, the inevitable progression, you know, all the way to stage 3. That's such a idea that I think a lot of people, especially patients, have, is like, well, I have lymphedema, it's only a matter of time before I have an elephant arm. No, it's not. And, you know, it's our responsibility as a healthcare community to really be intentional and be urgent and be firm with our education that this is a must. We must do this.
And if I can just jump in, because we had a great chat come through from, if any of you don't know Kathleen Lisson, you should check out her plastic surgery recovery book. She is a massage therapist and CLT, and I think we really need to make sure that we get the entire community. I know, you know, Linda, Gunter Close and Steve Norton, who run the schools, they're massage therapists, you know, their backgrounds are incredible. So, you know, I think we have to really, I love this slide, just, you know, went to be intentional, because we have to make sure that education is happening at all the different levels. And so I know Terry Kuti just said she'll see what her organization can do, her nonprofit, to help us move this along. And so, Linda, I know you've talked about some of these strategies. I think your thoughts on intentionality have been really profound. So.
Yeah, I think, you know, as I mentioned before, just thinking about how can we prevent lymphedema? How can we get ahead of things instead of always behind? And it's going to make care more efficient. I'm an efficiency freak and I love being efficient. And thinking about, you know, if I have 2 or 3 visits between my visits, the patient just refills. And then I'm kind of starting over again when they come back into therapy. So how can I be more efficient? How can I make every visit count? And in my opinion, in over 20 years of practicing, it's doing consecutive treatments. And if they are not getting custom, get their garment before you even start treatment. You can see what size they're going to be in and have them use that garment on the off days and on the weekend, so that you're not slipping back into swelling in between sessions. That's going to save the patient money. That's going to save time. And like you said, not only do the patients not want to be exposed because of COVID, but we also don't have the resources to be dragging out treatment. And so those are the kinds of things I think about, and I'm excited about. I think if we can decrease the amount of breast cancer related lymphedema by working more closely with our oncology team and doing things like the bioimpedance to reduce our lymphedema, doing things like giving them tools like the Belize bra that they can use to keep that swelling, or some kind of compression garment, a good garment that actually fits, and reduce our trunk edema so that doesn't progress into arm lymphedema, which is that's what always seems to happen. Oh, I've had this swelling in my trunk since surgery. I've had the swelling in my arm for a month. Well, where did that swelling come from? From the
Yeah.
trunk. So there's so many things we could do.
You'd love to know, Leslie Bell just chimed in the chat and she said, yeah, give patients a toolbox. Our patients need all these different tools. And so, you know, that's a pump, that's, you know, compression, like you're looking at some of that edema wear. It's a Belize bra, it's, you know, kinesio tape, it's exercise.
The self-measurement tool, you know, like the tape measure and whatnot. Yes.
Yeah. Go on, Elise. Oh, go ahead, Kim. I'm sorry.
I was going to say, even something as simple as like, look out for when your ring won't fit. Look out for if your watch won't fit. Like if your arm feels heavy, if you have mobility issues. People don't recognize those things as meaning a new disease process.
Yeah, and that's even what just one of the chat things said, education's key. Kristen Litz, thanks, said education is key because survivors are not told about it. Get insurance to cover garments. And let me just give a shout out to the Lymphedema Treatment Act right now. If we ever need this act, we're gonna need it now. So, you know, Heather Ferguson's amazing advocacy work on that, please get involved because we are, like I said in the beginning, not only the racial disparities, but the economic disparities are only going to morph right now with everything that's happening. We have 40 million people out of work. What's happening with health insurance? So I think all of you, as we said, we've got to give people tools. And that's pretty much what I've been running around this week doing too. And I want to throw this out to everyone. What does everyone think about 7-day-a-week treatment? Because Linda, what we've talked about before is, you know, the Foley Clinic doesn't give people the weekend off. They keep going with straight through treatment. Am I opening up Pandora's box with that?
No, so to jump in really quick. So I went to the Power Lymphatics conference in February, and that was one of the big things that I think it was Gunter, hope I'm giving that credit appropriately. But, you know, you look at the amount of treatment we do when we treat, you know, 2 times a week for 8 weeks. The number of sessions is the same when we're doing 5 days a week and then taper off. And for me, you know, we learn when we do our lymphedema training, you know, this is the standard, but then I think we meet resistance when we get out and we start practicing. And that really was a switch for me as far as it's not that different visits wise. And Linda, you really, I mean, they fill back up between the visits, you know, until they come in and see you again. And I think that is so important. We have got to adjust how we're approaching that.
And I'm just hoping that COVID might be the thing that pushes us to look at efficiency, because there was 2 great studies, Leduc and Yakamoto, I think his name was, in Japan, that looked at that most of the reduction we see happen in day 1, 2, and 3. Day 4, day 5, and the second week, we're seeing maybe some refinement. So, you know, if your patient doesn't want to come that much and they don't have that many copays, you are much better off doing 1 week. 5 days in a row, 5 total sessions. You're going to get a huge reduction and have that garment ready by Friday. Don't even start till you have that garment in your hand if you're not doing custom. If you're doing custom, you can't do that. But a lot of our patients don't have the insurance for custom. So you can be efficient and get huge reductions. One of the things that we're trying to do, I'm hoping to get off the ground, part of it is I need a rich benefactor to grant us funds for these research projects. But I've got a few years of data of us doing consecutive treatments and how much fluid we're reducing those patients by. And I'd love to show those numbers. They're huge. And and the average reduction is happening in sometimes 5 total sessions, 7 total sessions. We're not talking about 16 to 20 sessions, which is what most people who are doing twice a week. It's cheaper, it's more efficient, and we're getting big bang for our buck. And I'd love to be able to publish some of that data to show that it really makes a difference when you don't let them refill between sessions. This is the most efficient way to get them down. We don't need to do 7 days a week for 4 weeks. You know, we can't do that. We can't afford to do that. But if you even did 3 days in a row, you would get a huge reduction, much more than if you let them refill and did, you know, Tuesday, Thursday for 4 weeks.
So Linda, just to kind of clarify some of this though, this is where, when we're talking about proper diagnosis though, and proper stage of lymphedema, I've been a big early intervention person, and early intervention people don't need 5 days a week. My early intervention people, I see them once a week, and then I don't see them for 2 weeks. And I see them over a longer period of time to ensure the stability. And so I think, really making sure that we understand the difference between an early stage one, and then once someone has a chronic stage, and this is where I think we need to get the surgical voice in, and the way we're assessing lymphedema. Is it a solid component? Is there still a fluid component? What has happened? And remembering it's an inflammatory condition. And some people go right to that fiber fatty tissue. And so I think better diagnosis will give us better treatments and more accurate treatments, like you're saying.
Yeah, Nicole Stout published a great paper on some treatment thoughts. If there's less than 100 milliliter difference between the two arms, then you don't need to bandage. You can use a garment with MLD. And then if you're using a garment, then the garment can be put on 7 days a week, and you don't need 5-day-a-week treatment. So you're right. It takes clinical judgment to decide. But if somebody has stage 2 or stage 3, then I think consecutive treatments are really called for.
Absolutely. And Kim, I know, you're doing surgery. So, what's happening there, and what are some of the things you're seeing in terms of educating your patients who just think the surgeon's going to magically fix this?
Yeah, it does take, you have to do it pre-op, because you definitely can't tell them post-op that this wasn't a cure. So it is a lot of pre-op. One thing that we always tell our patients is that it does depend on the surgeon's expertise, obviously, but also the therapist, the patient themselves, their compliance. Patients have to be compliance hard, but seeing a therapist already, getting therapy with the therapist prior to surgery, so that they're same as what you were saying, even with ortho. You want the limb down prior to surgery to prevent wound healing issues, and for that to be better, and then needing therapy after you all end garments, new garments, and then doing it all within the constraints of a patient's insurance. So, as you know, that's always a barrier. But I love how you brought up the ICG, Maureen, because that is something you could see both ways. Like if that was used, the surgeons can sometimes catch things, like you said, sooner that you can't see with the naked eye. We've also had patients who maybe they felt that their arm with therapy never got better, but during ICG we'll see this is your pathways actually. Then that actually makes therapy much more effective.
Well, and I think that brings like what we have up on the slide right now. This we absolutely need this collaboration. I know, Linda, you talked about this. Elise, we talked about this in private conversations. And Kim, we've talked about this ad nauseum. I created this crazy diagram for your surgeons one time about how often have to be connected. And so I think right now what I'm trying to do in my local community is create like a virtual multi-D clinic with the different providers for my patients, because it's the only way I think they're going to understand the enormity of the problems that some of our patients are having. And it's not just in one person's wheelhouse.
Absolutely.
So I know, Elise, you were talking about some of the educational things too. Can you elaborate on that?
So specific to patients, or?
Well, patients, but also clinicians, because this is a big issue. As we've had a couple questions from different clinicians here about, someone was saying like they're never going to be able to treat on weekends or ever be able to, do something different than what they've been doing. So how do we start to enact that change? Like, how have you used your virtual platform to do that?
I think it boils down to you have to be a squeaky wheel. And that can be really tiring to hear, because sometimes it's really, really frustrating at the end of the day to be, conveying the same message and you're not feeling like you're getting anywhere. And that's, patients, fellow clinicians, all kinds of different things. But we really have to be the proactive members of our patients' healthcare team. And not just for that patient, but for future patients to really say, this is a big problem and we have ways that we can be treating them better, more efficiently, more effectively using these different things. And, I think we hear educate, but I am personally trying to, in light of COVID and what's going on, over educate. That was something that we had talked about in our exercise, but we know the language, we know the lingo, and so I have my mental checklist of, okay, I need to make sure that I cover all these things. But I think, going back to what Linda said earlier, having that 6-month follow-up where you can rehash some of those things, and maybe it's not a 6-month follow-up right away. I've had some patients where, they say, how about a month, or, I can come back in 3 months. So, when they're newer, trying to have more regular follow-ups and chances to make sure that they really understand what you've told them is absolutely key here.
It's exciting to think that with virtual health, that'll be easier than ever, Elise.
Yeah.
And we have Terry Kuti on this webinar, and she has a huge platform for patients on her Facebook group. So I think we definitely need to get Elise's measurement tools to them so that they can be proactive and we can catch things prior to even their breast surgery, maybe, because patients really seek out, Terry Kuti and others.
Yes.
Yeah, and she's again said, she'd love to help, and we're getting some really nice comments from, different people about even, if we get more therapists to know, maybe offer some little intro courses so they become aware of it. I think most of the schools have even a course that physicians can take. And I know, Kim, we've talked a lot about trying to get some further education into the physician at a training school, for example. It's great because you have, fellows and residents, and maybe we have some time to do this this summer before things really ramp up. So tell Dr. Fan we'll be calling him about that.
I always tell everyone that you were my paradigm shift, because like I said, in NP and MD school, you don't learn enough about lymphedema and how it literally affects, especially surgery and healing and swelling and
Yeah. Well, I mean, yeah, that could be a whole other webinar I think we could do, and maybe get them to do one that we could get the physicians in. But on this slide, in terms of home management, I've always been a big fan of this. I mean, it's that whole thing that people need tools. And I think in the last webinar, I talked about there's sort of an intersection of some of the thoughts we were talking about. And one is, when I first saw the ICG imaging of the lymphatic system, I was totally blown away. And for some of you who, again, that's the indocyanin green that they can image. The first picture was actually down in Texas. It was Dr. Carolyn Fife on the table like this, being the first human to get imaged. And she's a physician who's dedicated her whole career to lymphedema. And it was just so amazing to see, these pioneers of doing this, and people like Eva Sevek, Dr. Sevek, who's just amazing. And when I saw those, I said, gosh, these pumps really do work. And so that's where I became sort of an early adopter of the technology. And I know a couple of the comments on the chats have been to people saying, hey, I'm making sure I'm getting my patients a pump. And I know right now, I think I'm doing that earlier. In the 4 patients I've evaluated in the past 2 weeks, every single one of them kind of got to me late. 2 of them are having delayed reconstructions. They can't have reconstruction yet. They're all having truncal problems. I'm getting all of them, Linda, the stuff you were talking about, like the edema wear, getting them compression for the thorax. I'm getting them micro massage sleeves. I'm getting them pumps. What are you guys doing right now? Linda.
So for which patients are you talking about?
I mean, these were all women coming in with complaints in various parts of, 2 had just been recently diagnosed and couldn't get the reconstruction they want right now. And they're already having some post-op problems. And 1 more chronic after really bad radiation and really tough chemo.
Yeah. So, I mean, we are seeing those patients come in for treatment, some of them, and we are doing virtual health as well if they don't feel comfortable coming in. And We're doing assessment. We're doing the Strength After Breast Cancer program with our
Oh, Dr.
patients.
Smith's program. Yeah.
Yes, Katie Schmidt. We're doing that over virtual health now, offering that. So those are some of the things that we're trying to do. And I think, even if they come in for one visit for compression and fitting them with compression, and then we are mix and matching we might have a visit in person and then do several visits virtually, and we can go back and forth on either platform, which is helpful.
Yeah, I like that mix. I hope the insurance companies, and I think we really need to petition all of our insurance providers to continue this telehealth for rehab. Because Kim, we had talked about one of the reasons rehab was slow to it was that we weren't allowed to bill for it with except a few providers. And now that CMS has said we can do this, I hope they continue. I think we have to really politic for that.
Yeah, I think throughout healthcare in general, now that is going to be something that just becomes more of a reality. So hopefully we'll have better coverage.
Elise, how about, how much are you back in the clinic yet?
So I'm mainly back in the clinic. I'm not fully 100% back, but, going back to a point Kimberly made, we know that we have the ability and we can do so effectively, deliver our services through telemedicine. And truly, upon reflecting on just the landscape of healthcare right now, it makes so much more sense, truly, for some of our patients who are so immunocompromised that, even pre-COVID were at a risk of developing some kind of, opportunistic infection and then winding up in the hospital. And I think being able to serve patients in their home, where a lot of times they're most comfortable, is definitely a wonderful thing. And that's where we need to be prepared to spend more time in meeting our patients where they're at, especially because unfortunately we don't know what the next few weeks and months are going to look like for us as practitioners.
And Kim had mentioned a patient who had a scratch and wanted to, those were perfect examples of patients that don't need to come in necessarily, that we could visualize those kinds of things and provide the reassurance that they're often looking for and protect them from not going to that urgent care center. So I think there's just so many opportunities that it kind of blows my mind that we didn't do this before. And it's exciting to think that we have all these different scenarios that we can do more safely and more efficiently from home.
Yeah, and from the chats coming in, it's really interesting. A lot of people are posting about some of the different Facebook groups, and that those can be a good source of information. Sometimes they scare me too, depending. I think they need to have a good moderator like Lymphy Strong. Give a shout out, because without that, sometimes some of the groups, you see some very interesting things that probably aren't medically correct. And there was also a comment from someone in industry, and aside from amazing things like tonight giving us this space to talk virtually across the whole country, what are some things that do you think we need from industry, or what do we need from our institutions?
There are, I know we had kind of talked about, there are things like FlexiTouch where it's kind of, doesn't do the same thing as a therapist, but, and even Ready Wraps and certain wraps that at least give the patient some type of, I guess, a lot, like some items that are easier for patients to use at home. I mean, I don't know because I'm not a therapist, but are a lot of your patients actually able to wrap themselves or perform MLD, or do you feel like you have patients who kind of like fall off the wagon after they're not seeing you for therapy?
Linda, I'll let
So
you.
I think, having a solid home program is a part of your job that, I don't release a patient until they have either a bandaging alternative or bandaging themselves, and a good garment. If I release them before they have those things, then I really haven't done a very good job, because we know that they're going to just fill right back up. So that's a huge part of my job. So one of the things I thought of when you asked that question, Maureen, is thinking about getting like a good compression garment issued as a part of the cost of surgery. Because if we can issue that inpatient, and then they'd have that tool for the next year. If we got like a pad and a bra that could be used for that next year, then it would be paid for as a part of the surgery. And we wouldn't be struggling for 2 weeks when they finally come to us with early lymphedema in the trunk, or maybe not early lymphedema. And we're struggling for 2 weeks with the DME to get coverage, and we're wasting time getting
Yeah.
that trunk edema under control. So I think, again, collaborating with oncology and letting them know, look, if you can get this bra covered during surgery, you're going to help the patient and help your outpatient therapist hit the ground running whenever they have a swelling event in the trunk. So I think it's just time to re-look at everything we do
Yeah.
and figure out how we can do it better.
100% agree with that. Rethinking and re-examining how we've been doing things. To an extent it's been working, but it's not working very well right now. And
I
when we're going to get back to this, pre-COVID kind of experience.
Well, Elise, I think what you're bringing up right now is so interesting. There were just some very big studies that were done and just released in one of the journals about all the information that was collected from Lymprint that the international, the ILF did. Mm-hmm. And the US was, I think, a little bit in it, but I didn't see a lot of US data. And I think that's one of our problem is we need more data, and we really need to collaborate though. I've been working after the last webinar with Kimberly's group down at Georgetown with one of the medical school students, one of the surgeons, and we've been collaborating on a fast track article about these issues. Mm-hmm. And what the editors wanted from the journal was more data. I said, well, it's very early. We don't have a lot of data. So I'm going to put this out to everyone out there. All you data geeks, please start collecting data, even if it's just in your own clinic. We have got to be able to have something we can offer up to researchers, to industry, to the insurance companies, and say, look, here are some interesting things we found, because I don't think it's ever going to go back to how it was. And I don't think I'm a doomsday person, but I just think this is transformative in a very harsh way right now, but we're going to find the good things to come out of this.
Mm-hmm. I agree. And I think that's been very apparent even thus far with, our colleagues shifting so quickly to be able to meet patients where they're at and ultimately still be able to treat them effectively, either in or outside of the clinic.
Yeah. And, two interesting comments just came in. One about, working in home care, oftentimes they need things like the reduction kits, the Velcro binders and things, because bandaging is so hard in the home care setting. And someone from industry, again, asking what can we change that would increase compliance and make it easier for patients. And I really have to put this out here right now. I was talking to a colleague down in Dallas about this last night, and we need a second set of hands for most of our patients. I had an 80-some-odd-year-old lady come in today after a hip fracture. She has lymphedema in the leg already. The hip fracture happened in early March. And she really still has hip precautions, can barely get to her toes, and she has great flexibility otherwise. But without 2 pieces of adaptive equipment, I couldn't even get a liner sock on her. How is she going to take care of this on her own? She lives in a senior housing that they won't let anyone come in. And so I think we really have to solve a problem with, having access to another set of hands for a patient in their house. And they don't have to be skilled hands. We train families all the time. Why can't we create a legion of kind of volunteers that could learn to, help their neighbor put socks on, garments on? Because that's what is missing for the majority of my patients.
And I think, Maureen, you've been introducing me to creative solutions, since I've known you, and, thinking about the edema wear product with a Velcro on top.
Yeah.
Something really simple that even home care therapists, one of the things I've been trying to do is train PTs how to do some simple MLD just on their ortho patients, not to treat lymphedema, but to apply some manual lymph drainage and maybe edema wear to their knee replacement patients that don't have lymphedema, but we don't want them to get lymphedema. And we don't know which ones are going to end up having lymphedema because the post-surgical edema doesn't go away. And so I think thinking about introducing these tools to our general PTs and OTs, so they can reduce our caseload. They can learn these things very easily in a 1 or 2 day class. We just have to be careful that they're not treating lymphedema. But as long as we're committed to that collaboration, I think we've got to do things like that and hit things again, prevention, instead of always being behind the 8 ball with lymphedema.
An article just came out. It was just in one of the journals. I thought it was on my floor of my disaster of an office here, but one of the, I think, ortho journals just started to look at manual therapy, MLD style like treatments for ortho patients. So we'll have to find out who that is, and we'll make sure we get some of those articles out there to everyone, because we've got to run with those ideas. We absolutely do. And, I think, again, this is, getting down to what do the patients need. I had a woman who came in, and you talk about someone who had everything she needed, but she wasn't using it because she just hadn't had enough training on it. So, 2 visits ago, she came in, I taught her how to put her Velcro binders on today. Today, she was thrilled. Her legs are already down a couple centimeters. And then she also brought her Flexi Touch in because she couldn't get it on because she gained about, 30, 40 pounds. And so our session today was me getting creative with Velcro. And now I will call the rep, but in the meantime, until the rep can get her the proper size garments, she can go home tonight and use her Flexi Touch again. And I think I always have my patients bring their bags and boxes of stuff in, and I find out what tools they have, because there was a great comment from the crowd. I think it was actually Leslie Bell saying, it's great when they have all this stuff, but it's only good if they can use it. And I think that's a famous line. So, I think going back to at least what you said, over-educate. So I think that's, kind of what we have to do.
Of interrupting flow here, I just want to acknowledge that we're at the hour. The panelists have agreed to stay on for another 15 minutes so we can get through as many questions as we can. But just wanted to let people know that we have that time heads up, and we'll continue to answer questions that have come in for the next 15 or so minutes.
All right, so 2 comments I want to make from the, someone asked if the cltlana.org site is good to find therapists, and yes, it is. So that's the Lymphology Association of North America. Dr. Paula Stewart's the president right now, and Lana's really doing a lot to try to further the whole field of lymphology. It's not just therapists, but it's doctors and nurses. Kim, you can join. But they do have a very good directory to find people. And all the schools also have directories that you can call and find CLTs. And then another comment from and I'll put this out to the panel, but what would you think of a program that could get, let's say, PT or OT students to help patients in their home, something along like that second set of hands volunteer program?
Great idea.
I think it's a really good idea. And unfortunately, I graduated PT school 2 years ago, I think. I don't remember anymore. Oh my gosh. But, a lot of my classmates were very hungry to, just keep learning. And sometimes just getting to be out with another person who wasn't in our class or wasn't a professor was a really refreshing way. And I know several of my now colleagues and I were working with people, but not in a PT specific treatment thing. So I think that's a perfectly appropriate and much needed opportunity to, one, get students exposed to lymphedema, because we know there's not enough lymphedema or oncology period education in PT schools. Get them interacting with people, and maybe even get them interested in becoming a CLT and treating these patients at some point in their career.
Lydia, you were going to say something?
Well, it's funny. We had 40 physical and occupational therapists go through a 2-day training to treat their ortho patients with some MLD and simple bandaging. And I'm finding some of them now becoming full CLTs because they saw the power of manual lymph drainage on a healthy lymphatic system and how it would respond within a day or two, where these patients might have been struggling with some pain and lack of range of motion for a few weeks, and then a couple MLD sessions. And it is so fun when somebody has a healthy lymphatic system. You see those incredibly quick results, and they get hooked and they want more, and they become CLTs. So it's a great gateway to get therapists to become CLTs.
Yeah, I mean, I know, Kim, you could maybe talk, well, you talked a little bit about how, in nursing, you didn't get a lot of education about this. And we've talked about, maybe creating some programs in the medical schools. There was a nice comment from one of the attendees who said out at their hospital, I've got to find it here, but I think all the first year residents, it looks like, got in Minnesota, the first year residents do a week rotation in our clinic, including lymphedema, wound, and cancer rehab. So let's make that happen right now. Let's get these medical school students, they could save a little PPE and come hang out with us for a week.
I mean, lymphedema therapists are such a wealth of information, and it's hard to find an area where you couldn't be of benefit. I mean, just standard, even you mentioned just post-op edema. So standard, any surgery with edema can benefit, even if you don't have lymphedema. And I know that we've talked about that, and how many times have wounds not healed?
Yeah.
And then you get MLD involved, and now the swelling's down and the wound can heal. So there.
Yeah, that was a comment from the crowd. Just MLD is so much better than retrograde massage, and and it is. And although we are learning that there's some interesting techniques once we get ICG lymphography involved to find out where things are actually flowing. Our techniques are morphing. I know a lot of us are surprised to hear that we actually prepare the axilla, for example, in a breast cancer patients, even if they've had lymph nodes. I know Linda and I were just talking about that. That's an update in the teaching, because we know from some of the imaging that a lot of women still drain, for example, to the axilla, even though they've had lymph nodes removed. So, I hope that, and what I'd love to hear from the audience right now, or even any of the panelists, and this could be a topic possibly for another webinar, but, how to, and kind of what is going to be the best way to collect data that we're talking about here? How can we all come together and really, through our social networks that we have, get on similar pages, like, any thoughts on that? Or do you think doing things like this is helpful to bring us together and share these ideas?
There's been so many free webinars. I've attended so many webinars in the last month, which I love. It's been really exciting. And some I've disagreed with, and some have been really inspiring, but they all make me think, and they all connect me to other lymphedema therapists across the country. So we're not just in our little silo doing our own thing. And so I think, again, another positive thing that's come out of COVID is that we're talking more, and there's more free educational opportunities, which is great.
I think that's why I like going to conferences so much, is you get to get out there and connect with people who are practicing in different areas of the country, who have a different approach than you. And then you're hearing from people on the updated education. And so, conferences might look a little different, but you're right, Linda, there's so much free content out there for patients who are, and providers to just learn so much more that I think we're really able to take advantage of. And I think connecting in that capacity is a really great way to start these conversations and start those collaborations.
We finally got grant money for a support group. I've been wanting a lymphedema support group for years, and we just had our first Zoom lymphedema support group this past week. And, it was great. It was funny. One lady had her phone at her feet the whole time, but you know what? She told us how she was doing, and it was a success in my mind. And so I think, again, we're just going to reinvent ourselves, and we're going to figure this out, and we're going to do what we need to do. Just maybe not in the same way we thought.
Well, Linda, I think that really sums it up for a lot of what we were even trying to do. I know when I approached all of you about this clarity card exercise, and when I told Matthias what we're doing, and just thanked him, because again, this is he puts this out there for the world to use. And so, if people want to do this on their own, we have the instructions that you can do this exercise. I know we all found it really helpful to do together. And, I want to give each of you, just we only have a few minutes left here, but 30 seconds, just any final thoughts. Kim?
I feel like even being part of this, I don't feel like you're all in different states or far away. I mean, now I have all your email addresses. I'm just like, Linda, oh, we should do this. Or like, I can be like, Elise, send me what to do. Share your podcast. So I think that's my takeaway.
Linda.
Yeah, I agree. I'm hoping to recruit Kim to collect data with me on the bra project. She's interested and excited. And yeah, I guess I would just say, you try to rethink things. Let's all rethink things. And even don't throw the baby out with the bathwater. That sometimes the people that invented CDT, they knew what they were doing. And even though we may not be able to do 5 times a week for 4 weeks, but what if you did, 5 times a week for 1 week for those patients who are really concerned about coming in and exposure? Like, don't throw the baby out with the bathwater. Commit to good quality care, and you can do that even in COVID times.
Yeah, thanks. And Elise?
Yeah, one of the things that Linda said when we were doing this brainstorming, initial exercise was, this is a time to dream. And that's really stuck with me over the past few weeks. And I think it is, again, whether we're at home or in the clinic or, in whatever capacity, this is a really great opportunity that has kind of been forced upon us, where we have some time to sit back and kind of re-examine and reflect on what we've been doing, and then think about how we can continue to improve patients' lives, but maybe in a little different way, or maybe in a better way, and then to act on those dreamings and that, brainstorming and just collaboration that we've been able to come together for over the past couple months and move forward.
Well, I want to thank all of you, because this was what I wanted to have happen. And, I know Terry Kuti just said to all of us, the spirit of collaboration has been amazing, and thank you for the passion and focus on patients. I want to give a shout out to, I think, the furthest person away, my colleague Lilian Melo down in Brazil. So we've been worldwide now. And, with that, I just want to thank Tactile Medical, Sarah Yannick and Megan Mosbeck. They've been amazing with their support for our community to do this, and I know these are really tough times. I just want you all to know that we all care so much about everyone out there. As Linda said, and all of us have echoed, connecting together as lymphedema therapists. We used to be ghost therapists, just out hidden in our rooms all day. We're coming out. We're not going to stay in our rooms anymore. We're going to connect. We're going to use things like this. And please know that we care so much about everyone's safety, the safety of our patients, our communities. And I know Tactile and I know all of us here are really committed to being part of the solution. And we just want to thank all of you for being here tonight and being part of our community.